really want to thank everyone for having us here today. It's a phenomenal opportunity to engage with all of you, and I appreciate your time coming to see our presentations today. So I'm going to go over some basics. I think Dr. Beard's presentation, we didn't coordinate, but she said a lot of things that I think will be really, really meaningful um, to my talk as well. So just kind of in broad strokes, as you're all aware, there is a difference between ulcerative colitis and Crohn's disease, and that has important implications on how we treat these and manage these things surgically. And I'm very, very lucky that as a what we call scalpel jockey, I have really intelligent GI colleagues who can help direct me in taking best care of patients. And it's very, very important. Crohn's and ulcerative colitis are just like cancers in a sense. You have to have a multidisciplinary team of people who are helping to take care of the disease process. So in our case, by the time anyone requires surgery, our GI colleagues have generally really exhaustively gone through every option with patients possible, and surgery ends up being something that is done to treat a lot of symptoms of disease that are no longer responding to medications. In ulcerative colitis, the disease is completely confined to the colon, starting at the rectum, and it will continuously progress upstream but stay within the colon. In Crohn's disease, you get disease anywhere from the mouth all the way to the anus, and typically it will skip segments of the intestine. So as Dr. Beard mentioned, what we end up doing for patients, particularly in Crohn's disease, very much depends on your individual characteristics, because no Crohn's patient, or UC patient for that matter, is exactly the same. And so just in terms of disease features themselves, you'll find with Crohn's disease that you have pretty early inflammatory manifestations, often characterized by cramping disease, versus ulcerative colitis, where we'll find that patients often present with bloody diarrhea as one of their main early symptoms. What we're finding as surgeons is that in this current era, we seem to be having better success with medications for ulcerative colitis, simply because 40 years ago, the only treatment for a lot of the disease processes was just steroids. And as time has progressed, we've found that a lot of the patients who have ulcerative colitis do quite well on the myriad of medications that Dr. Beard just mentioned, versus Crohn's disease, where it's still the case that about 80 to 90% of patients with Crohn's, particularly when they're diagnosed at a young age, will progress to requiring surgery of some type during the course of their lives. I have a lot of things that I've written up there, but I mentioned that you'll see a different disease profile for the Crohn's patients. So about half of Crohn's patients have disease in the very end of their small intestine, called the terminal ileum, where it's coming up to the colon, while about 30% will have just the disease in the terminal ileum. And most patients have some component of small bowel involvement. Again, that has an impact on what it is we end up doing operatively for patients. So when you look at the anatomy again, I've kind of listed out where you'll see where patients have disease. It's more common when patients have downstream disease that if they have a failure of medical therapy to be managed, they may end up requiring ostomies, and I'll talk about that a little bit further along in the talk. We find that the patients who have this isolated ileocecal disease often are the patients who do best with an operation, meaning if you don't have perianal fistula, if you don't have midgut Crohn's disease, but you just have your disease at that area where the small intestine is plugging into the colon, there is a better chance that if you get an operation, which still requires medical treatment afterwards and close surveillance, you may only need the one operation and not multiple additional operations. So what are our more modern surgical options for patients? As I mentioned, most patients will require surgery within a decade of diagnosis when they have Crohn's disease. So I'm going to talk about Crohn's first, and then I'm going to discuss ulcerative colitis because the options of Crohn's are more myriad since it skips through the intestinal system. But even in the era of medical treatment, a number of patients will progress to requiring disease, and in fact, requiring surgery. And in fact, the most common reason that we end up doing operations for patients with Crohn's is what we call medically refractory disease. So that's basically disease that despite a number of different medical treatments has failed to respond properly. And most patients in those circumstances will start developing weight loss, real difficulty tolerating food, often having bloating and difficulty having normal bowel movements, or if they're having chronic inflammatory disease that's not controlled by medication, weight loss because of that chronic inflammation and diarrhea. We will not pursue elective operations in patients until we really know that we've suppressed your inflammatory disease and done everything we can with our GI colleagues to try to treat that. And so it definitely does require a multidisciplinary approach. Any surgeon who's going to be your surgeon needs to have a close relationship with your gastroenterologist, and they really have to have discussions before and after your operations to make sure that the right approach is taken for you. So just general principles for surgery. Surgery is not curative in Crohn's disease. It is really there to treat symptoms that are otherwise refractory to medications. The risks of having operations, which are the ones that patients are often concerned about, is need for having an ostomy, developing short gut, which means that if enough of your intestine is removed, you may end up having difficulties absorbing nutrition properly. And that can require modifications on diet or sometimes go so far as to needing IV nutrition if you can't absorb properly enough. Again, one of the reasons that we really want to make sure if we're doing an operation that we've worked with your gastroenterologist to do everything we can to properly avoid an operation so that we don't have to remove more intestine. And then when patients have, I mentioned that patients who have just that confined ileocecal disease tend to do very well, but if you have ileal disease that doesn't stay in that confined segment, it's a lot more necessary to progress to having an operation in general than if you have disease in your colon. So I just have a little list there of the main reasons to require an operation. As I mentioned, failure of medical management is the most common reason. That actually will get kind of grouped with intestinal obstruction because often failure of medical management results in chronic inflammatory disease that becomes a stricture. And the way that I like to describe strictures is it's like your intestine normally it does the wave and it's very soft and pliable so that things can move through it. It has several layers of muscle that helps push food along. When you have chronic inflammatory disease, the nature of the intestine changes and it's almost like it becomes concrete. And then you have these isolated segments that things cannot pass through, and that can result in obstruction. So those first two are really the most common reason in Crohn's disease we'll end up doing an operation, followed by inflammatory masses that create abnormal connections either between loops of intestine or between the skin and the intestine. And that's seen a bit more commonly when patients have perianal fistulizing disease. And then there are the emergency reasons, which is having a perforation that causes a need for an emergency operation or bleeding. Those are far, far less common, particularly in Crohn's disease. Because it's so hyperinflammatory, patients will tend to develop inflammatory mass as opposed to free perforations. So when we talk about failure of medical therapy for patients, I've mentioned several times now, it's really to treat side effects and the failure of the medications to control the disease. And that inability to stay on medical treatment is another reason that we'll consider surgery. So a number of these biologics will have some disclaimers. If you read a bottle of aspirin, there are a lot of FDA disclaimers. So it's really hard as a patient to know what you do and do not need to be worried about. But your gastroenterologists are the ones who are aware in your family profile if they have a concern that you have a significant malignancy risk in your family history, or if you have a personal history of cancer. It sometimes eliminates the ability to be treated with certain kinds of medications. And that will be one of the reasons that they'll often send folks to us to take a look at you to see if surgery is important to be considered. This is just a picture of what intestinal obstruction can look like. And I know that can be gross for some folks. I should probably always say, sorry, this might be a little bit concerning to have to see. But what you see on the left is just a picture of a small bowel follow-through study, which is where we have patients drink dye and watch how it goes through the system. And what you'll notice there is it almost looks like if you had taken a balloon and twisted it at certain areas. So you have strictures in some areas and then it balloons out in between. And what that results in is these areas where it's very challenging for food to pass through normally. So when patients have stricturing disease like that, particularly when it's a long segment, we will talk about doing an operation because that's obviously going to get in the way of being able to eat and drink normally, and you'll get bloated and have a lot of pain. That can also result in little areas of bacterial overgrowth that can contribute to diarrhea and just generalized illness. Small segment strictures, if you have one small segment stricture, sometimes the gastroenterologist will be able to actually dilate those strictures. The picture I have here is something that is just too many segments consecutively to be dilated, and that's when you talk about proceeding to an operation. And in that circumstance, we remove the area of the intestine, particularly if it's the first operation, we'll remove that segment and then reconnect the intestine. One of the other reasons in Crohn's disease we'll do surgery is if you've developed an infection, which is an inflammatory abscess where it's contained because the intestine has become very inflamed, developed an abnormal perforation that the body then contained, and sometimes can cause segments of intestine to abnormally connect with one another. So those are called intraloop fistula. And when your body naturally bypasses, say, from your small intestine to your colon, that also can cause malnutrition because you have a whole segment of your intestinal system that's not being used. So it's another circumstance where the surgeons step in. We're just glorified plumbers, so all we're trying to do is fix the plumbing is what it comes down to. When we talk about CT-guided drainage, if you have one of these abscesses, even though immediately your surgeon may recommend a drainage of the abscess, the need for a long-term, for an operation in the long term is typically pretty high. And again, one of the things that we're always thinking about as surgeons is how do we take the least amount of intestine out and do the least bit of harm to a patient. So when a person has an immediate flare, we'll often say we'd like to try to do everything we can to reduce the inflammation and sometimes delay surgery until we know there's less inflammation, because the less inflammation there is in the body, the better chance we have not only of decreasing the amount of intestine removed, but not accidentally injuring other surrounding structures, such as in women, their ovaries and their pelvis, in women and men, the tubes that drain the kidneys called the ureter. Those are always the strategies that your surgeons are going to be thinking about if you have these acute flares. And sometimes the reason that patients will experience a delay before they progress to surgery. This is another picture of what a spontaneous fistulization of the skin can look like. So that's a segment of intestine as it's coming up to the skin with an abscess and starting to drain. And so these are circumstances in which the body has almost developed an ostomy of its own. The thing about stomas is that when we fashion them for patients, we do them very deliberately so that we can make them very functional to pouch. When people have these fistulas that are draining to the skin, that are spontaneous, they're very challenging. They can excoriate the surrounding skin and cause a lot of discomfort for patients. So those need to be addressed almost universally with operations. As medications have gotten better, so the medications that Dr. Beard referred to as anti-TNF drugs were the first generation of drugs that actually showed some success in spontaneously healing these fistula. But you have to remember that if a medication has healed a fistula, there's probably still some abnormality of the intestine around it. And in the long run, those patients will often still progress to requiring an operation. Just another picture of what an abscess can look like between loops of intestine. The mesentery is just the blood supply of the intestine. So when patients develop fistula, they can either develop them outward between loops of intestine, or they can develop them inward into the blood supply of the intestine. 35% of patients with Crohn's disease of the small intestine will develop advanced disease, which are intraloop fistula, and as I mentioned, some of the medications do well to help heal that, but it still often requires an operation. One of the things we always are concerned about in patients who have Crohn's disease and fistula is malnutrition. So any operation should be accompanied with a really deep discussion around preoperative nutritional status, how to address postoperative nutritional status, because that has enormous impact on how patients heal and decreasing the chance of complications after surgery. There are certain other kinds of disease processes in Crohn's that will always require an operation. So if you have an abnormal connection between your intestine and your bladder, or an abnormal connection between the intestine and the vagina, those universally require operations because the medications aren't, they typically will not heal those kinds of fistula. And so there are going to be certain kinds of patients who your gastroenterologist will say, it's important you meet with a surgeon early because I know you're going to need this. And I really appreciate it when GI docs send me patients and say they're not ready for surgery yet, but it's really important you have the discussion because it's really overwhelming. When you have to hear what the possibilities are around the operation that you may have, one visit really isn't enough for me to say, okay, I'm going to operate on you. You have to be able to process what the possibilities are. And so in my mind, when the gastroenterologists tell me this is exactly where a patient's disease is located, I've formulated a plan around 2 or 3 options that we may be seeing. And being able to talk to a patient in advance and explain those options, I think, is really, really important. This is just a picture, again, of what it looks like to get an abnormal communication between the small intestine and the colon. And you can see that contrast dye is passing into the colon, even though a lot of small intestine hasn't filled up. And that's the body naturally bypassing a big segment of intestine. When we talk about doing operations for intracutaneous fistula, everything is really dependent around your nutritional status. So sometimes if your nutritional status is not great going into surgery, but you need to have an operation, a temporary bag may be necessary. What that allows to happen is it gets rid of all the draining stuff from the skin. It allows an intentional ostomy to be developed so a patient can eat and drink well and get control of what their skin is like. And then you go back later when the patient's nutrition is much, much better, which will give a much better chance of a connection and healing. And that's paramount in surgery. You want the connections between the intestine to heal well, because if they don't, you can have problems like sepsis, which can be life-threatening. And you can have other problems in Crohn's disease. If an intestinal connection leaks, it can promote development of more fistula, which is just a chain of really unfortunate and dramatic events for patients. So finally, peritonitis and hemorrhage, again, very uncommon reasons in Crohn's disease to have surgery. So our modern surgical principles remain the same. This is the same surgical principles from 40 or 50 years ago. And one thing I mentioned to patients, as was referred to earlier in this morning, I think people don't, it's a silent disease in the sense that people often don't know who has Crohn's disease. President Eisenhower is one of the most famous examples of a famous person who had Crohn's disease, had 2 operations during the course of his presidency. A lot of people aren't aware of that. And so it's certainly the case that surgery can dramatically improve quality of life. And we know when we look at quality of life indicators for patients, Crohn's disease is one of those disease processes, and ulcerative colitis, where when patients ultimately do have surgery, quality of life improvement is dramatic, and many patients feel like they don't regret having had the operation, so it's important to remember that. As I mentioned here, and I referred to earlier, strictureplasties through a camera, an endoscopic strictureplasty can only really be done for small segment disease. One thing that we know is that whether or not you have Crohn's disease at your margins in a microscopic sense doesn't predict whether or not you're going to get Crohn's again. So we do try to take out all the disease we see when we do an operation. It's evident to the eyes because in Crohn's disease, the tissue is thick and it's not like the remaining intestine. But even if we were to get microscopic margins and they said that you had a little bit of inflammation there, while it may make us want to be quite aggressive about continuing Crohn's treatment, which we would do no matter what, it doesn't mean you're going to be at greater risk of requiring an operation again 5 or 10 years from now. We always favor removing the intestine as opposed to just bypassing it, which was the thing that was done 20 or 30 years ago. And the reason for that is if we leave an inflammatory wad in a patient, they still often feel the discomfort from that. And having that chronically inflamed area contributes to malnutrition and continuing symptoms. The main reason to do a quote-unquote bypass where we don't take anything out but we just hook normal up to normal is if we're worried that removing that part of the intestine could cause a problem for a patient. Like it's so plastered down in the pelvis that we're very worried we would injure a major artery trying to remove it. Then that might be done. But it's quite uncommon to do that. When we talk about strictureplasties, and strictureplasties are really just us not removing the intestine, but cutting the stricture and re-sewing it so we can open it up. We'll tend to do strictureplasties in patients who've had repeated operations so we can avoid continuing to remove intestine. And there are different kinds of strictureplasties you can do that just have different names because surgeons like to name things after themselves. So there's short segment strictures, longer segment strictures, and really long segment strictures. The bottom line is that when they've done studies on all of these patients, the strictures, the disease doesn't come back in the middle of the stricture because the stricture by definition is burned out from its inflammatory process. What ends up happening is that disease comes back upstream or downstream of the stricture. And so our goal is always to try to create an area where there's not high pressure and where there's as much normal flow through the system as possible so that, again, it's just plumbing so that things feel as natural and normal for patients as possible. Just a little bit of data there. Strictureplasties help quite a bit with symptomatic relief, and they relieve obstruction. And when you end up having a strictureplasty done, like I said, it's quite uncommon to get recurrent disease in the middle of the strictureplasty, but about 30% of the time it can happen upstream or downstream. So again, we really try to reserve doing strictureplasties in patients who've already had 5 or 6 operations. And the last thing I'm going to discuss from a Crohn's standpoint, because it comes up a lot now, and you may see it on the internet, is talking about doing this Crohn-OS anastomosis. One thing that we want to do in patients with Crohn's disease, they have inflammatory disease that involves the blood supply and the intestine. We try to remove the inflammatory disease involving the blood supply because that can be an area where additional inflammatory cells can get to a fresh connection. But there's been a discussion about how the connection should be done. And the bottom line is, when your surgeon's thinking about giving you a connection again, they need to try to give you a nice, wide open connection so that it minimizes the risk of you getting stricturing there again. And that's just a technical standpoint. So the Crohn-OS anastomosis is something that's being discussed a lot more amongst colon and rectal surgeons. It's just a way of putting a connection together so that it's nice and wide open to minimize the chances of getting disease again. Surgical outcomes, again, show really significant quality of life improvement. 90% of patients surveyed who get operations for Crohn's and ulcerative colitis have an improvement in their quality of life. But there are significant risks. The main risks to patients are risks of bleeding, and then early complications typically surround how wounds heal and infection. When we talk about minimally invasive surgery, laparoscopic and robotic surgery are now increasingly mainstays. 20 years ago when I was training, anyone thought it was crazy to think about doing one of these operations on a patient through tiny incisions. As we've advanced in our abilities to do laparoscopic and robotic surgery, which both have equivalent outcomes with one another, i.e. robotic surgery is not superior to laparoscopic surgery, but it's often used because it can keep you from having an open operation. We do know that though patients may still have a long length of stay in the hospital because they've had chronic problems eating and drinking, the long-term outcomes are better for patients. Lower risk of hernia, quicker return to work, better wound healing. So it's worth it in the long run, although you may still have a prolonged hospitalization because people who've had blockage and not been able to eat and drink properly, it often takes longer to get to the point that you can eat and drink properly. And then just very briefly in ulcerative colitis, because not a lot has changed, when we do an operation for patients with ulcerative colitis, because the disease inherently involves all of the colon, our goal is to, if you need an operation, remove all of the colon and the vast majority of the rectum. We can do this in 1, 2, or 3 stages. It's a very successful operation when we know a patient has ulcerative colitis. It is not a very successful operation if we think a patient has something that's closer to Crohn's disease. And so, in general, if a patient has Crohn's disease that only involves their colon, we do not recommend getting something called a J-pouch. And a J-pouch is just removal of all of the colon and the creation of a new rectum out of small intestine. So if you have something closer to Crohn's disease, where you're much more likely to get disease in your small intestine, it makes sense that you would not want to make a new rectum out of small intestine because you would have a higher risk of getting disease there again. So that's a circumstance if you have Crohn's just in your colon and the medications don't do well for you, where there's a higher chance of needing an ostomy. When we do this operation, we leave a very small amount of rectum attached to the sphincters that control continence, and we connect that new small intestinal rectum to that little cuff so that we're able to maintain continence for patients. Because there's always a little bit of disease in that little cuff, it will mean that your gastroenterologist will continue to need to survey you periodically to make sure that you don't develop any complications in the cuff itself. And that's all I have. Thanks for, and I'll be happy to address any questions afterwards.